as I have learned a lot while preparing this lecture. So let's begin. Now, emergency doctors, not many things will shake emergency doctor, cardiac arrest, their heart rate will probably go up a bit, difficult intubation, it will go up to 100, managing polytrauma in shock, yeah? But if you really want to scare an emergency doctor, all you need to do is you say, you remember that patient you sent home yesterday, yeah? That really will scare them because because we do sometimes, very rarely, send patient which we should admit home. And one of them is a patient presenting with chest pain. In 2007, our CPG guideline says about 2 to 8% of patients diagnosed with chest pain was misdiagnosed and sent home, and probably this causes some morbidity, if not mortality. Yeah? So emergency physician, one of the main claims of malpractice is to failure to accurately diagnose AMI. So it's a ticking time bomb. So today we will learn about tips and tricks of how to diagnose and manage this potential bomb. Yeah? So chest pain is quite common. In your hospital, I'm sure every day in the emergency department, you will get patients complaining of chest pain. In IGN is even more because we are a cardiac center. So the emergency doctor has to determine which one is serious and which one is not. And not all chest pain is acute coronary syndrome. It can be other conditions which are also life-threatening. For example, aortic dissection, yeah, pulmonary embolus, pericardial tamponade. And we have to decide which one that require admission and treatment, and which one we can discharge home. And how do we do that? From the history, we look at the patient itself, the demographics, yeah, physical examination is very important, but we also need to do investigation, and various investigations are available. The main one is ECG, so that's what we will concentrate on today. Now, ECG is central in the decision of chest pain. When you're working up someone with ischemia or infarction, it's very important for us to do ECG. Now, the AHA 2020 ACLS guideline categorizes ECG into two sections. Number one is ST segment elevation. We normally diagnose STEMI. This is when everyone gets excited, and we give priority to this kind of chest pain. But it's also very important for us to be careful because there are also STEMI mimics, for example, aortic dissection. I'll have a case later on. Or maybe Brugada, these are ST elevation, but they are not acute myocardial infarction. Now, the other group is non-persistent ST segment elevation. And this group of patient, basically, they don't have your typical ST elevation. They might present with ST depression, some T-wave inversion, even a normal ECG, but they are actually STEMI equivalent. Yeah? It's very important for us to diagnose this and not discharge. So most of our cases will concentrate on the STEMI equivalent. This is your ECG, and your ECG leads will represent different portions of your heart. Most of us would remember this better. So the inferior leads, 2-3 AVF would represent the inferior leads ECG. Your lateral leads, yeah, lead 1, AVL, V5, V6 will be your lateral leads, and your anterior leads from V1 to V4. However, cardiologists, when they see ECG, this is what they see. They see the artery because any ST elevation, they will have to decide which is the culprit artery and zoom in on those arteries. Yeah. Okay. So let's begin. One thing about ST segment elevation, it's important to analyze actually the ST segment morphology. It can be concave, yeah, it can be concave up, or it can be convex. This is the one that we're a bit afraid. Convex, we're concerned, or it can be straight like that. So just based on this morphology, where the convex and also the straight is actually quite specific for STEMI, for ST segment elevation, as compared to the rest. For example, BR, yeah, what's BR? BR is more concave as compared to convex. So just by zooming in on the ST segment morphology will help you decide whether this is ST elevation which you should be concerned or not. Now, Amal Mattu coined this sign, check mark sign, where if you look at the V2, it's straight. The ST elevation is straight, so you have to be careful. and you have to suspect ST elevation or early changes of ST elevation. And if your ST segment elevation is higher than your R wave, this is what we call your TUM wave pattern or TUM wave STEMI, which carries significant morbidity and mortality. So just be careful. So let's begin. Case number 1. This is quite recent, last month. 57-year-old Malay male, from Kuala Lumpur. Actually, he was admitted a few days before for non-STEMI and discharged home while waiting for an IGN appointment. He has some risk factors. On the day of presentation, he had complaint of chest pain 3 hours prior, and it was 3 out of 10. When he came in, this was his ECG. So this was at 11:20, and you can just have a look very quickly. Nothing exciting. So he was given double antiplatelet. He was given sublingual GTN, and his pain was relieved. And we observed him and referred to cardiology for admission, and probably for coronary angiogram. However, his pain recurred, and it was very severe. And his pain is a typical chest pain. He was holding his chest. When you look at him, we were concerned. So he went 10 out of 10. What do you do when there's a recurrence of chest pain? We do another ECG. So actually, this is ECG number 3. ECG number 3 at close to 1 p.m. Again, nothing much there. There's no ST segment elevation, T wave inversion, yeah. So again, we because of the severity of the pain, we had to give him morphine. His troponin came back and it was not raised, but do remember that this was very early, 3 hours after the chest pain, so the troponin might be falsely not elevated. Yeah, and the emergency physician, my colleague, Dr. Farina, did an echo, and it looked okay. There's no obvious regional motion abnormality. We gave him morphine, and again, the chest pain relief. And we repeated even another ECG. At about 1. So he was okay, waiting for admission until close to handover time at about 2 p.m. Again, there was recurrence of chest pain, which required IV morphine, quite severe, and we were planning to give him IV GTN because of his persistent chest pain. This ECG, nothing much there, but because of the chest pain, we repeated another ECG. So this is ECG number 6, yeah? And before that ECG was done, we echo him again, and there are changes. The inferior wall seems to be less contractile. Repeated another ECG about 15 minutes later, and if you have a look, there's ST elevation in the inferior leads, yeah, with ST depression in AVL. Just to compare, this was the previous ECG. When you look at the so with ST depression in V1, V2, V3 as well, so we suspect posterior involvement. So we repeated the posterior lead ECG, and if you can have a look at V7, V8, V9, there's a little bit of ST elevation. We repeated the right-sided ECG, and if you can look at your RV4, RV5, RV6, there's also a little bit of ST elevation. So actually, this patient had an extensive myocardial infarct. Since he had right ventricular involvement, we did not start the IV GTN. So he had posterior STEMI with right ventricular involvement. He was pushed to the cath lab, and he had severe stenosis of the mid-RCA, yeah? And it was stented, and he had good result. So again, a point for us to make is ECG is very important. You have to do serial ECG, repeat your ECG, and it becomes more sensitive and more specific for ACS, yeah? All right, and why does that happen? STEMI doesn't always show itself at the initial ECG, and about 1 to 10 to 1 to 20 STEMI are only diagnosed with repeated ECG. Yeah? So high-risk patient, please repeat your ECG every 15 minutes. Please tell your staff nurse, please repeat ECG at 2:30. Yeah? Don't say 10, 15 minutes. Time is relative, so give them a time so it's been done, or you continuously monitor your patient. Okay, case number 2. This, again, was also last month, 70-year-old, typical chest pain with risk factors. This was managed by Dr. Daniel, my MO, and he called me, and if you can have a look at the ECG, it's tachycardia, 150, 130 to 150. Patient was complaining of chest pain, but relatively comfortable, not in failure. But the BP was a bit on the low side, 85 systolic to 100, but she doesn't look in distress. She was quite comfortable, but it was concerning because she had tachycardia, and also the BP was a bit low. So if you have a look at the ECG, you can see it's tachycardia, irregular. So basically this is AF. So you can say patient has fast AF, possibly unstable. But when you look at the ECG further, you can see that there's some ST depression in lead 2. Yeah, maybe V1, V2, possibly V3. Yeah, so we suspect a posterior myocardial infarction. Diagnosis was non-STEMI since the troponin was bumped. And if you look at the initial ECG, there's ST depression, there's prominent R wave, and also upright T wave in V1, V2, V3. When you invert the ECG upwards, it becomes ST elevation. The prominent R wave becomes a Q wave, and the upright T wave becomes T wave inversion. Yeah. So is it a non-STEMI or is it a STEMI? So we did a right-sided ECG, nothing much seen on the right-sided chest leads, but on the posterior ECG, yeah, you can see a little bit of ST elevation in V7, V8, V9. Just blow it up a bit. So there you go. So what does the patient has? Patient has acute posterior myocardial infarct, but she also has unstable fast AF. So we synchronized cardioverted her 200 joules. She reverted to sinus rhythm. If you can see the ECG, it's sinus rhythm. However, her BP was a bit low, so we had to start some vasopressors, and she was pushed to the cath lab. And on the cath lab, in the cath lab, she had multiple vessel disease. But the cardiologist consultant zoom in on the culprit lesion, which was the RCA and left circumflex, based on the ECG, your posterior myocardial infarct. So a little bit about posterior myocardial infarct, ECG finding, V1, V2, V3, any ST depression in V1, V2, V3, with prominent R waves, tall, upright T waves. We have to suspect posterior myocardial infarct. It occurs normally with inferior and lateral MI. How to confirm this? Please do your V7, V8, V9 ECG leads. Just quickly, V8 is at the tip of your scapula. V7 would be at your posterior mid-axillary line. Now, if you look at the orientation of your V7, V8, V9, it's exactly opposite to V1, V2, V3, and your posterior wall is behind. So that's why when you get ST elevation in your posterior leads, on your 12-lead ECG, it actually shows as ST depression, yeah, in V1, V2, V3. So any ST elevation in your posterior leads as high as 0.5 millimeters is considered diagnostic for posterior MI. Now, posterior MI accounts for 15 to 20% of AMI. It usually happens with inferior and also lateral MI, but like in our case, it can happen in isolation, less common, about 3 to 11%. And the culprit artery is mainly the left circumflex and the right coronary artery. Yeah? It's the most common missed myocardial infarct, and it's important to diagnose because it will benefit from reperfusion therapy. So it's very important for you to diagnose posterior myocardial infarct. These are the additional lead ECG which you should do. So basically, if you suspect posterior MI in the setting of inferior MI or lateral MI, and also if you suspect any ST elevation in your right-sided leads. Yeah. Okay, let's move on because we're short of time. Case number 3, quite interesting case. If you look at this, it's a 70-year-old lady with typical left-sided chest pain. I'll just brief a few seconds for you to have a look. Now, when you see something obvious pointing out, is basically your probably ST depression in your inferior leads. So you're thinking, is this inferior ischemia? But remember that your inferior leads is the opposite to lead 1 and AVL. So please zoom lead 1, nothing much there, but have a look at AVL. There's a little bit of ST elevation in AVL. So this is actually high lateral myocardial infarct. Now, just to introduce to you or revise the concept of reciprocal changes. Now, anything in your lead inferior, especially lead 3, is the opposite to your lateral leads, especially AVL. So any ST depression in lead 3, please look at the changes in AVL and vice versa. Yeah. So we learned just now that on your horizontal axis, your V1, V2, V3 is the opposite of V7, V8, V9. However, on the vertical axis, lead 3 is the opposite to AVL. And Patient was pushed to the lab, and she had occlusion of the first diagonal branch of the LAD, and the diagnosis was high lateral myocardial infarct. Yeah. So what changes do you get with high lateral? It normally shows as ST elevation in lead 1, lead AVL, yeah, and sometimes in V2. I think some of you are common with the South African flag pattern, but also you will get ST depression in your inferior leads, yeah, 2, 3 AVF, especially in lead 3. Okay, but remember that ST depression does not localize in terms of ischemia to the region of the heart. It's not like ST elevation where infarction happens, yeah? So when you get an inferior presence of inferior ST depression, do not diagnose inferior wall ischemia. Important to remember, if you get ST depression in your inferior leads, please think about the reciprocal leads, and they should be high lateral STEMI unless proven otherwise. Okay, case number 4. 50-year-old general practitioner complained of typical chest pain. I remember this case because he's a GP, and he actually told our staff he's having a heart attack. But we had a look at the ECG in the triage. Our paramedic didn't pick up any ST elevation, so he was put outside just to wait a little bit in the green zone. But later on, he was brought in because he was complaining of more chest pain. And have a look at the ECG. You can see T-wave inversion in lead 1 and also lead AVL. Now remember, look at the opposite lead, lead 3, lead 2, nothing much there, nothing much there. So we repeated an ECG. A few minutes later, I just want you to highlight that lead 3. Just remember that. We will cover that too. So lead 3, nothing much there, but the T-wave seems a bit tall and broad. So what do? We did a ECG, and lo and behold, there's inferior MI. Yeah, inferior MI. So let's compare with the initial ECG. Look at lead 2. Lead 2, sorry. Okay. So there's ST elevation in lead 2, but before that, nothing much. It's just broad T-wave. But look at your lateral leads. There's T-wave inversion. There's T-wave inversion in your lateral leads, which later on became ST depression, yeah? ST depression. So what do we learn from this? Number 1, patient having symptom, please repeat your ECG. Number 2, listen to your patient, especially if they're medical doctors. So this is, again, about reciprocal changes. So if you have new T-wave inversion or ST depression in lead AVL, look at the opposite lead. Look at the inferior leads, yeah? So you have T-wave inversion in AVL, look at your inferior leads, and please figure out if there's anything happening there. Reciprocal changes can be T-wave inversion, or then we'll change to ST depression. Yeah. So remember the opposite lead. You see ST depression in 1, check the opposite for ST elevation. Yeah. Now remember that lead 3. So basically, high peak T waves is a subtle sign of early ischemia. There's excessive large broad-based T wave. So your QRS, if your QRS can fit the T wave, that means that it's in hyperacute T waves. And just for comparison, this is your hyperacute T wave. It's broad-based, broad, yeah, huge as compared to your hyperkalemia, which is tall, symmetrical, and slim. All right, quickly, case number 5. If you look at this, it's tachycardia, white complex. Now, most of you will think, is this VT? Is this SVT with aberrancy? Just a simple rule. Anyone with a white complex tachycardia with symptoms, in this case chest pain, well, number 1 diagnosis is VT, number 2 is VT, number 3 is VT. Yeah? So white complex tachycardia, which is unstable, electrical cardioversion, you assume it's going to be ventricular tachycardia. Now there are other pointers for you to figure out whether it's VT or SVT with aberrancy, which I'm sure will be covered by the other speakers throughout this day. Just quickly, the white complex unstable, we treat as VT. If it's stable, you got time, you can discuss and look at your algorithm, drink coffee, or even call your cardiologist or your EP team to decipher whether it's a VT or not. Yeah, and this is the basal algorithm, a new algorithm to differentiate VT and SVT with aberrancy. It's quite new. I think it will be covered by the other speakers throughout the day. Now, very quickly to case number 6, this is very important, very exciting case. We got this ECG, 49, BP was okay, but his heart rate ranged from 175 to 300. Just have a look really quickly. It's a very interesting ECG. There's wide complex, there's narrow complex. The rate ranges from 100 to 300. So it's irregularly wide complex tachycardia. Now remember, his BP was okay. So my medical officer was preparing an amiodarone to give, and we reviewed the ECG. It didn't seem right. This is a very bizarre looking ECG. So we had a look in the old notes, and luckily he had one ECG done many months prior, and this was his ECG, old ECG. So if you can have a look, it might be too small for you to see, but there are some delta waves. So basically this guy had Wolff-Parkinson-White. And Wolff-Parkinson-White, or pre-excitation rhythm, whether it's AF or flutter, in the setting of AF is very, very dangerous. You have to avoid any drugs affecting your AV node. When you give drugs, it might cause a patient to deteriorate further. So if you get a wide complex tachycardia, irregular, it might be because of pre-excitation, and the treatment is basically electrical therapy and not drugs. So patient was synchronized, was given cardioversion synchronized 200 joules. This was his ECG later, which showed similar delta wave. So it was a close near miss, and we actually planned him for admission, but he took an AOR discharge. Okay, this is probably the final case I think we covered today because we're short of time. Very interesting case. It was a very challenging management case. 56-year-old man with risk factors. He was admitted to a private hospital in Kuala Lumpur many days prior. He had inferior posterior STEMI, but it was thrombolized, so it was successful. However, post recovery, he had angina, and his ECG showed complete heart block. So he was symptomatic, and not only that, there's short runs of non-sustained VT. So he was put on IV lignocaine, and they brought him to the cath lab. He had mid-RCA, he had RCA occlusion, which they failed to cross. So the patient was referred to IGN. So when he came, he was on an IV lignocaine infusion. On ECG, he had complete heart block. His BP was borderline, but he was in and out of VT and VF as well. So if you can look at the rhythm strip there, if you can look at the rhythm strip, there's actually a ventricular ectopate beat very close to the T wave, and then it deteriorated into VT and later on VF. So we had to shock him, and then he reverted, and we continued with the lignocaine because of the VT, but his heart rate was slow, and it was a mess. So we were scratching our heads. Should we continue with the lignocaine? He still had VT, but the lignocaine might precipitate his bradycardia. So me and Dr. Jai were scratching our heads. So what did we do? Well, we had to breathe, and we had to pray for divine intervention and figure it out. So basically what the patient had is he had acute ischemia, which caused his complete heart block. And with the complete heart block, the SA node, the AV node is not pacing, so the ventricles is trying to pace, but the ventricles being unstable precipitated VTVF. So this is bradycardia dependent ventricular rhythm. What did we do? We had to pace him transthoracic pacing in the emergency department. He was pushed to the cath lab, and a temporary pacemaker was inserted, which later on converted to a permanent pacemaker. And look at this ECG, beautiful. He stabilized, he became asymptomatic. This is the last case, I think, very quickly. You have a 57-year-old male with risk factors complaining of chest pain. Nothing much on the examination. His troponin has been bumped. However, he had some renal impairment. Sorry, he did not have any renal impairment, so his troponin was bumped. So the diagnosis was ACS. But on further investigation, his X-ray showed widened mediastinum. We did a quick bedside echo. The aortic root seems a bit dilated, and back then we tried a different view, the suprasternal notch view, and you can have a look of a flap. There's a flap there at the aortic arch. So we pushed him for CT pulmonary angiogram, and he had a type A aortic dissection. So you can imagine if we gave this patient double antiplatelet with anticoagulant, it might worsen the condition. Yeah? So basically, in your ACS guideline, management of ACS, it has a section where you should do a chest X-ray to exclude aortic dissection. So just bear in mind that not only ECG can be used, but we also have to use other modalities. For example, chest X-ray and your bedside echo is very valuable in assessing patient with chest pain. So ladies and gentlemen, I think we come to the end of the session. A bit of take-home messages. ECG is very important to be used in your department, whether it's in emergency or the ward, but you have to know its limitation. It's very specific but not sensitive, so use it to rule in but not to rule out. Please do serial ECG, repeat, and think about additional leads, for example, the posterior and right-sided. Now, it's important for you to assess the ST segment, whether it's convex, rounded, or straight, and that might be an early sign of ischemia. Remember your reciprocal leads, any T-wave inversion in lead AVL, look at your inferior leads. Any ST depression or T-wave inversion in the inferior leads, please suspect high lateral STEMI. Remember your hyperacute T-wave, look at your T-wave closely. If your QRS can fit in the T-wave, it might be an early sign of ischemia. White complex tachycardia, unstable. Remember, white complex tachycardia, unstable, electrical therapy. Assume it's VT unless proven otherwise. Anything bizarre looking ECG, white complex, irregular, think of Wolff-Parkinson White in AF that requires electrical therapy. Remember your bradycardia dependent ventricular rhythm, yeah, and your VEBs, your RONT phenomenon, important for you to fasten the heart rate or pace. And finally, beware of aortic dissection, other causes of chest pain, which is not ischemia, and that requires a better history, better physical examination, your bedside echo and chest X-ray. Thank you very much. These are my reference. So I hope with today's cases, you will be able to